Welcome to another episode of What Brings You In Today.
I'm Erica Bennett.
And I'm Taylor Fisher.
And today we are joined by Dr. Robert Kirtley, MD in Interventional Physiatry. And Dr. Kirtley, what brings you in today?
Well, welcome and thank you for having me. I am coming in to talk about interventional physiatry.
All right, not to be confused with psychiatry, which we also have an episode on that if you're interested in listening to it. So tell us about yourself, Dr. Kirtley. Just give us a little bit of your background and kind of what led you to becoming a physician and to your specialty.
Okay. So I think really when you grow up and you have this competitive nature in your family, and so I grew up with older brothers and multiple cousins, and they were all athletes, and I was the youngest, and so I would get dropped on my head and have to punch above my weight class, and so it makes you have that competitive attitude, and a lot of water skiing and athletics and competition, working out, and getting into metabolism and physiology, and so that pathway took me into medicine in general, but I think the family background is something that kind of made me want to reach for more. I have it's interesting, but my aunt is a world slalom champion and water ski champion, and my grandmother was considered the grand old lady of water skiing by Mastercraft Boat Company.
Oh, and wow.
So my brother went to
Your
college.
Your family sounds very interesting. Must be fun on reunions and stuff.
Thank you. It was fun growing up, very different, but everybody had some type of title or championship, and so it kind of drives you to find your place in that, and so I felt like finding my groove and in general learning how to be a little bit out of the box of a thinker, and so. With retail business and the work and the competition. So as far as, being into physical medicine and thinking about exercise and physiology, that really took me down a route of loving to be hands-on with patients and understanding a lot of the orthopedic and neurologic things that I do. And so that route of, really was almost physical therapy at first, and then I got into physical medicine, and so it just drove me into becoming a doctor in that route.
And so what is interventional physiatry for everyone? Let's go ahead and get that question out of the way.
So 2 words, interventional. When you think about the word interventional, you've heard of interventional cardiologist, you've heard of an interventional radiologist. And so to intervene is to typically do something, have an action or a procedure at a body part to try to fix or intervene in some way, in contrast to a normal diagnostic physician or treating with medical therapy and medicines. And I do both of those. We'll diagnose and we intervene, and I'll use medicines as well. But the tricky part is physiatry, and a lot of people get confused with that. And so it's not psychiatry, and it's not a physiologist. But we are one of the smallest specialties in medicine, physical medicine and rehabilitation. And so in general, a physiatrist is a PM&R doctor. And so the PM stands for physical medicine, and the R is rehabilitation. And so classically, over the years, most physiatrists or PM&R doctors have been rehab docs. And so they would run a rehabilitation unit or, after major surgeries or a severe debility, someone would be on the rehab unit, very similar to what we have here. And those docs will round and make sure they're, recovering and getting better and get them back to a fully functional state so they can live autonomous, right, or go home independent. But being military trained, our focus was a little bit more on the physical medicine side because we needed to be able to deploy or be at a duty station and act as, this orthopedics, this neurology, this sports medicine, and even pain medicine. And so I was very fortunate to be where I was, and my pathway in becoming a doctor was very unusual, and I'll tell you why. But, we had this exposure of be able to diagnose, intervene, and make someone feel better and actually give them improvement, right? Be able to affect change. And so in so many words, I am the PM part of a PM&R doctor, and then I do a lot of interventions. And so that's what interventional physiatrist is. Excuse me.
All right. So tell us, you mentioned the military. Tell us a little bit about that background.
Sure. With typical docs, you get interested in something, you rotate it, and then you do a residency. And I was in the health profession scholarship program that took me in and helped me pay for school. And so I was very fortunate to get that. And so I started off at Triple Army Medical Center, and I did my internship there. I matched into radiology, and so I started off training in radiology after my intern year, and that's where I had my first exposure to ultrasound and kind of fell in love with it. However, I didn't fall in love with, driving to work in the dark, working in the dark all day, and then going home in the dark. And so I felt like I was turning into a vampire, and I was losing that contact with patients. And so, and in the military, if you want to change, you can, but you kind of have to pay up front. And so I did leave radiology, and then I went and did aviation medicine, which is also known as aerospace medicine. And they call us flight surgeons. And so I did aviation medicine training, and then worked out of Fort Rucker in Enterprise, Alabama for a number of years, and got a ton of general practice experience. And then also you get to fly in helicopters and, be a flight surgeon. It's really neat. And so
it's pretty cool, I guess.
It's fun. And believe it or not, flight docs in the Army, if it's what's called a single rated airframe, that means, say a helicopter that only requires one pilot, we could get stick time. So it's like the old MASH, doctor up there, getting some stick time, as long as there was a pilot there. But it was a great experience. And from there, then I applied to Walter Reed's PM&R program. In short, Walter Reed was seeing all of our service members throughout, and this is from 2013 to 2016 timeframe. And so we still had a lot of service members that were coming back from downrange and very unfortunate injuries, right? And so IEDs and blast injuries. And as a new resident transitioning into that big hospital, I'll give you an example and try to put yourself in that position. And this is another reason why it makes you want to reach for more, to try to offer more. And it's what also kind of helped me develop a unique specialty in that. So Walter Reed had something called a amputee clinic. And then eventually we also developed an ultrasound clinic. But that amputee clinic, say as a new resident, here you are, and there's literally 50, 60 amputees in wheelchairs, and they're coming in, they're fresh from flying in from Landstuhl or downrange or Afghanistan, and so these young men have lost their legs, right, and not just both legs, but also an arm, and so and then as a new resident, first thing is, let's choke back the emotions, and they're coming to me for help, and still you're new and you're learning, and so the normal process, right? If that happens to somebody, what do? So you've got to wait for an appointment to the surgeon, and then you've got to have your surgery, and then you got to wait because they've got nerve pain, they got to wait for an appointment to neurology, and then you've got to wait for an appointment to maybe the neurosurgeon, and then you're going to see wound care, and then you're doing, you've got all of these appointments, and it's taking forever. We needed something better, right, for service members that had and they're in pain this whole time. And then what do we want to do? Just throw pills at them and narcotics? No, we don't want to get them hooked at the same time. So we integrated in this ultrasound clinic and why ultrasound? Well, the technology around that time started to get better and better. We had an amazing budget, multiple rooms, each room filled with a $100,000 plus ultrasound machine. And then we would do electrodiagnostic studies, and then we had pain suites right there. And so no other place could you have one facility, right, with fluoroscopic pain suites, and that's like a C-arm, right, and then these ultrasounds and the electrodiagnostic studies. So you could bring in a patient, especially in the ultrasound clinic, and they're in pain. We could see them for the first time, do a new evaluation, immediately start doing imaging, right, in the same visit, right? And ultrasound allows you to see dynamically. It has better resolution than MRI, and at the same time, it's dynamic. That means you can move it and evaluate, have them move their leg. You can see how the muscle, the tendon's working, right? And then so as you're doing this, you're also now, you find a problem. Oh, there's a big neuroma, right? Their leg was transected, right? And that nerve is angry. That's part of either the blast injury or the surgery. And so now, well, what can we do? And so we had the ability to use regenerative medicine, which is still what I'd call the wild, wild west of medicine, right? PRP and stem cells, things like that. It's still not widely accepted because of reimbursement. But so long story short, we had access to all these things in one place, right? And nowhere else could you do this. You can't, evaluate someone, do imaging, and do an intervention all in the same visit, right? And so it offered the ability, you had to do it and really get good at it quickly because I mean, you got somebody that you don't want them to commit suicide, right?
Right,
They've lost
yeah.
both their legs and they've lost an arm, right? In this case. And so you've got to get over your emotions. You've got to dig down, and it really drives you to offer something better, right? Because there they are. You're in that position at the largest hospital
Yeah.
for all the armed forces, and they're coming to you. What can I offer them, right? And so am I going to make them wait to go see someone else? No, they're here for this pain, right? And this is you. And so definitively, I fell in love with it because I already had this ultrasound background from radiology, and then I'd already been using it in aviation medicine. And so it was just like this match made in heaven for me because, and I embraced it. When sometimes other residents didn't want to go, I volunteered and I took their spots. And so I just ate the ultrasound up in the ultrasound clinic. And I guess over the years, we started integrating in all these additional procedures, utilizing radiofrequency ablation, utilizing regenerative medicine, and then other treatment techniques, prolotherapy, lots of things that you can't get on the outside. And that formed who I am today in my practice. And coming out into the civilian world, it was some tough lessons for me because you can't always get these things approved in the civilian system, right? And so learning, but I retained a lot of that. And still, it's very exciting. And I think that's why we get a lot of hugs and happy folks because we still integrate a unique way of providing healthcare. And people just don't know what PM&R is, right?
Right.
I'm evaluating a bone and joint issue. I'm evaluating a nerve issue. I'm evaluating a sports medicine issue and a pain issue. Think about pain, right? You want to see, quote, a pain doctor. What is that, right? Every pain you have is mediated by a nerve, right? And so it's not just, right, a joint pain. It could be a nerve issue. But
Well, I tell everybody about you and your specialty because I've actually seen you several times. I had a sprained ankle, and you were able to tell me, like, hey, it's going to heal probably. Like, let's just walk it off, no pun intended. But and it did after a while. So that, I didn't have to have any kind of intervention or whatever. But being able to, you had that ultrasound and, looked at it real time, looking at a ligament and being able to see. Tell us about the difference between an X-ray versus a ultrasound for just the common folk, because mainly X-rays are typically what are used, like if you go into like an orthopedic practice. Ultrasound, how is that different, and what leverage does it give you versus the X-ray?
Well, excellent. Thanks for pulling me back on track. I get a little worried sometimes. So absolutely. X-rays are one of our oldest modalities, right, of imaging. And so when we're transmitting X-rays, it does have radiation. So there's the downside of it. However, X-rays are fundamental, right? And so I'm not here to say that one modality is better than the other, right? Just as we use them together to make and get a more full picture. And so I ordered lots and lots of X-rays. However, I don't always need them, right? And so when we're talking about ultrasound, what it does is it's using sound. And just like the reason why that when during a pregnancy, right, ultrasound is the safest modality we have, it's using high-frequency sound and an echo, right? And that echo is bouncing back and forth. And the technology uses that speed of as it bounces through different densities of tissues. It does a calculation, and boom, shows you a beautiful picture. But
And shows you a spot-on picture of your child, like
I
your
had no
face.
idea that
like the
that's
3D
how that
ultrasounds that look. My son came looking exactly like that. I mean,
it's amazing, isn't it?
It's crazy.
Right, it really is. Well, the technology's gotten better and better over time. And so we keep a high resolution. I have actually 2 ultrasounds, and so one that I do surgery with and then one that I utilize for most diagnostic work. So keep it in the office. It's immediate. It's cheap, right? And there's no damage or no pain to the patient. And so you can ultrasound as long as you want, right? And it's very easy to do.
And you were able to tell because my ankle was still swollen, so you looked at my other ankle to see what my anatomy should look like, and you were able to tell that I had sprained it previously, years before that I forgot about. How do you know all the tendons and ligaments? How do you, because there's so much stuff in there.
Right.
There's all kinds of stuff in our bones. And
absolutely.
How did you learn all that? I mean,
in general, it's the background in imaging, and so just like a radiologist that goes into training, you learn you look at these imaging, right? You look at imaging on a day-to-day basis, and then when you start putting, when you see a muscle, when you see a tendon, when you see bone, or someone who's damaged bone, even arthritis, it has a very telltale appearance, and it's easy to pick up on that, and and being able to do that in the clinic visit, right, speeds everything up. I'm not having to bring them back to send them over to the department and have something done. So it not only does it save the patient time, it saves them money. And then also the next step is using that same imaging to then, if you say, for instance, you want to deliver medicine to a specific spot, and if you look inside the hand, if I had, pictures here to show you, right, there are so many structures, right, nerves, vessels, arteries, tendons, and an injection can have such a good outcome when the medicine's placed in exactly the right spot. And sometimes these are less than a millimeter, right? You need high precision, and so that's the whole point of using that ultrasound during visits. And when it goes to the right place, it's a huge game changer. And so the way I describe it ultimately is kind of like a video game. You've heard of God mode or a cheat code, right? And sometimes it's almost like it's not fair, right? Because if you traditionally went, oh, let's move that shoulder around, let's do this, and I do that same thing. I move that shoulder around, but why not also let me see inside you? Like kids with, like we imagined when we were young, X-ray goggles, right? I put on my X-ray goggles and then I'm that's what I thought it was, long head bicep tendon, right? And so you can see all of that. Now there's limitations as well, but it's very, very helpful.
So speaking of your practice, what are the most common complaints that people come to see you for? Like what kind of issues or pain are they having?
Good question, thanks. So I actually practice from head to toe, and docs like myself sometimes get pushed into a route because what do all of us have? We all have back pain. Often it's so common. So I do a great deal of spine and low back pain and issues with hips and knees and shoulders are some of the most common. But I actually treat from head to toe. And so, but specifically musculoskeletal peripheral nerve. So, but again, nerves mediate everything. So if we started at the top of the head, right, and you have migraines, right, and that can be a supraorbital nerve that lives there, and I can go after that. If it's at the back of the head and people are getting migraine headaches, and that's called occipital neuralgia, I go after those nerves. Moving into the neck, right, I go after the arthritis, shoulders, and literally all the way down to plantar fasciitis. And so one of the cool things here is that there is, traditional approach of, hey, let's just go after the tendon. The tendon's thickened, and so we might be able to do surgery on a tendon. Well, if you can find the tiny little nerve that goes to that thickened tendon, what would you rather have done? Would you rather have a surgery that opens the foot and then cuts that tendon? If it's still intact, it's just causing pain, so you're having the surgery for pain. Then go after a tiny little nerve without cutting you open, heating the nerve up and killing the pain, right? And guess what? You can do that all over the body.
Yeah,
and
that's so cool.
It's just a different approach, right? And we do that all day long, every day, right? And so then that's part of what leads into some of the unique things that I do as a nerve specialist. And so what brings people in can be chronic elbow pain, right? But instead of saying, well, hey, after physical therapy's failed, or if, say, I've got a patient that's got chronic knee pain and they've already had a knee replacement, or they have, morbidly obese or comorbidities, and they're not a candidate for another knee replacement. And so I literally find the nerves in the knee, and then we can heat them up or cut them, right? And that's because otherwise, what were they relegated to? Pills, just pills, and or steroid injections that no longer work. So there's room for improvement. There's room for alternative treatments, and that's where, I try to step in, and we're even doing IRB-approved research here, right? My colleague and I, Dr. Mackey and I, are very excited to be working on a new procedure, and it's exactly that. It addresses this unmet need of people that have chronic pain and otherwise aren't a candidate, or they still have pain in their knee. And
yeah, well, like my dad has chronic lower back pain, and he's been told you can have surgery, but surgery doesn't necessarily always help. Like you could have the surgery and it would help, but it also might not. And he just doesn't want to have the surgery. I mean, and you can understand you're having back surgery. You can't do anything for a long time, and he doesn't want to take pain pills. And he's already had prescriptions, and he doesn't want to do a whole bunch of pain pills. So listening to you talk, I'm like, maybe I should get my dad an appointment to come see you because it might be helpful.
I know this, it's so weird. Like, also, my mom has back problems, and she went to Dr. Mackey and Dr. Kirtley, but I think Dr. Mackey said the same thing. Like, if we do surgery, you're just not ever guaranteed, right, that it's going to work. And that is, cost benefit thing that you have to kind of weigh in. And a lot of times it's scary to think about doing a big surgery, especially if you're not guaranteed.
Sure. I mean,
and you can manage the pain. The pain is not like unbearable, but
So sometimes, and let me clarify we're not trying to imply that we can take the place of surgery.
Right.
Sometimes you have to heal with steel. There's no way around it, right? And so with someone, there are specific indications, right, for spine surgery. And I won't get into that specifically, but if you've got bone on top of a nerve root, then my medicine's not going to make a difference. And then there are nerves that say we could do an ablation, and that term refers to typically a heat energy, right? I'll use some heat on certain nerves, and that's what's called an ablation. And I can stop pain for a long period of time by doing that. But then you have nerves that have motor function, meaning that, hey, they move your leg. And then if I do that, I don't practice again, right? That's a no-no, right? So people need to walk. And so those types of nerves we can't heat or do an ablation on, right? And so if you're losing function, it's pressing on your spinal cord, then there's no way around it, right? We want the best outcome from a pain perspective. But if it's going to impact function and ability, and that's where the surgeon has to step in, right? Relieve that pressure on the nerve and then allow them to get back to their life. Now, yes, I mean, when you cut through skin and muscle and connective tissue and bone, a perfect surgery can be done and they still may have pain. And so that's tough for our surgeons, right? And so you have to stand by them and help folks with, once it's pretty bad, you're going to get surgery, right? Or however we can help you the most, do the least amount of harm. And so certainly, like in your dad's case, if it's pain, then we may be able to help him with the pain, right? If the muscles are still functioning, then he may not need that surgery, right? But so hopefully that helps.
Well, it's just cool to see medical advancements, I guess, happening right here, locally. And I mean, as just a citizen, I'm like grateful for people like you that are out there looking at ways to make things better and not just settling with status quo. I think that's pretty cool.
Yeah. It's funny you say that, buck the status quo. That's a term that I started to use years ago while I was still in the Army, and so now I even work with some folks that's their mantra is buck the status quo. With advancements. Speaking on about nerves, one of the things that's interesting is I started seeing difficulty while I was still in the military about, say, getting something approved. And why could it not get approved? Well, they said, well, it doesn't work. So why doesn't something work? And so using that ultrasound, let's take the knee, for instance, and I have a little show and tell I wanted to explain, is that, with being able to now visualize nerves that transmit pain into the knee, so how could I cut those nerves or damage those nerves or stop someone's pain? Some research showed where animal studies were utilizing high concentration anesthetic, and that anesthetic, I'm going to use two terms, neuroselective and neurolytic. So neuroselective meaning that if I put a medicine inside the body, it only affected the nerve, right? Neuroselective. And the other term is neurolytic, meaning it cut to lytic to cut. It cut the nerve, right, or damage the nerve. And so we got very excited from these two studies, right, the animal study, and then also there's some studies for exactly what we're talking about, back pain, right, where high concentration numbing medicines were being used in people's backs. And so based on that, some years ago, I started working with my colleagues back at Walter Reed, and then we ended up, this is a medicine that I developed, and so I got with a compounding pharmacy out of Atlanta. And so you won't see, your physicians and patients will never see this, right? But it's 20% lidocaine, right? It can be very dangerous because it's a very high concentration. And we had to supply the compounding pharmacy with all this literature, how it would be used, and so to get it developed. And so we started doing, based on that research, I wanted to use high concentration anesthetic in specific nerves for someone who'd already had, right, multiple surgeries on their ankle or multiple surgeries on the knee. And then instead of cutting them open, why not? It's the holy grail of medicine, right? Just inject this tiny little bit of medicine that only affects the nerve, right? And then kill the nerve from functioning. And it's not a motor nerve, it's a sensory nerve, right? And so that was the impetus of a lot of this, is that And it worked for a few people, but we couldn't quite figure out why it wouldn't work for others. And then I also had 75% dextrose developed because, this osmotic effect, and I don't want to bore you with it, but it was, the other effect was, again, try to kill a nerve. It's kind of cool. And that led into...
You're just trying to earn a title to compete with your grandmother.
That's kind of cool.
I was curious, how long does that medication last? Is that just forever?
No, but that's why it has to damage it. Right. So a numbing medicine only lasts for a few hours. Right. But if you have a high concentration anesthetic, it can actually lesion or damage the nerve. And so.
And then that lasts for whatever?
It would last forever. Yeah. Right. And so and that's what happens there are different types of nerve damage. And so you can have temporary nerve damage, and then you can have permanent, right. And or something that's equal to a transection being cut. But to answer your question, yes, the goal was that medicine would then destroy the nerve so people then would walk without pain. Ultimately, what it led to was the research that Dr. Mackey and I are doing now. So I find those nerves and we transect those nerves, and it gives people hope, right? I have people, and I love to get them in front of the camera where they're talking about, wow, I had no options, and now I'm walking without pain, right? Certainly there's some that have not worked as well, but the overwhelming majority are working, and we're very excited about that. And so
we held an event where you spoke about that procedure, and we had several patients that had that procedure speak at that event too, and they were just raving about what it did for them. So tell us about this other contraption you have over here.
So,
another procedure you do that's minimally, we see minimally invasive stuff start coming and becoming more popular. I do feel like we're just going to keep moving in that direction.
Oh yeah. So this is really cool. So in 2013, when I first started my residency at Walter Reed, we looked into something called the hook knife, and so we knew that there was a better way because, again, ultrasound allows us to see inside the body, right? So nicely. And there was this physician who developed this little device that had a hook on it, literally. And so they were doing carpal tunnel release with a hook knife. It was a little bloody, but it showed proof of concept, right? And then later we started developing, and I started these engineering drawings for a deployable cutting blade. Well, some material engineers got together and some folks, and they did a much better job of it, right? And so
you didn't have to invent that one.
That's
you just
right. And
got
so
blessed. Someone else did that
exactly.
first.
But before this was around, there's a physician named Dan Zugo, and the U.S. Army sent me to Green Bay, Wisconsin, to train with this guy, and it was very neat. It was a thread carpal tunnel release, and so he was doing a carpal tunnel release without cutting the hand at all, right? And so fascinating. He used this echogenic wire, a wire that could be seen under ultrasound. He went to China and he did hundreds of cases, and then he came back and then showed and did the literature, and so we were going to introduce this in the U.S. Army population, and so there was, whenever you start to cross over into another fields, there can sometimes be a little bit of a turf battle, and so and it takes it's just healthcare, right? It takes some time to get things approved, and so the Army was a little behind, and only just this last year did they start doing it. But as far as the way this works is that the really neat thing is it's based on using ultrasound. And so traditionally, if you're going to do a carpal tunnel release, you're cutting downward through the palm and opening, or it can be done endoscopically as well, but it's a pretty large device that goes in the hand. We want to be minimally invasive. So this device is intended, there's an incision that I can make it so small it doesn't even require a stitch. So utilizing ultrasound, there's a little safe zone, and it will basically go right into the wrist, up under the ligament. And so now it has a tiny blade that if you see, can you see how small the blade is? That's the thickness of the transverse carpal ligament. And then it can also be manipulated up and down a little bit to control, right, my depth. And that can transect, it goes back inside and hides itself once it's complete, and then it pulls right out, and then you're back to using your hand immediately. And so the cool thing there is that you can see everything. So again, it's that God mode, that cheat code, right? You can make sure the whole ligament is cut. You can make sure that your safety parameters, it has balloons that allow me to manipulate the nerve. And also think about this, I'm cutting up and not cutting down, right? So you don't have that same risk of cutting into the nerves or tendons or causing damage. So improved safety profile.
How many people suffer from carpal tunnel? Do you know?
Oh my goodness, millions. There's roughly 2.3 million cases diagnosed every year, and it's one of the most common elective surgeries done in the United States and around the world.
And how you do the procedure, how long does it take, and then how quick do people see results?
So yeah, great question. I literally I don't have to do general anesthesia. We listen and we chat about music right during this procedure. It takes about 7 minutes, and then I have them fully move and use their hand immediately after the surgery. Their hand will be numb for about 20 hours or so, but they're back to using their hand right afterwards. Now we did cut the ligament, so if people have a tendency to be a little bit more sensitive to pain or needles, then they may have some soreness, right? But most people do very, very well because it is surgery inside the hand. It does cut the ligament, but we cut so much less. We don't damage any of the aponeurosis. We don't damage any of this tissue. We don't the palmar cutaneous nerve, right? They're able to immediately use the hand the next day. And the company that makes this device, they have nurses when they need, and the nurse literally has it done, and she's back to work. And
my gosh.
joke about she's literally right after surgery.
Yeah.
So it's really, they call it micro-invasive, not minimally invasive. So meaning even smaller than minimally invasive.
Wow.
Pretty neat.
So this is in-office procedure, or is this considered an outpatient kind of
It
thing?
actually can be done inside the office. At my old clinic, my private clinic, I was doing it inside the office. One of the things that I'm very thankful for SGMC for is, that transition. I came out of the military. I had a private practice during COVID, and then also trying to be a military doc in the civilian world doesn't always work. All right, and so those hard lessons of, hey, I can't see somebody, diagnose them, imaging, intervene on the same day. Guess what? The hard
There's
lesson
rules.
is,
There's
it
rules.
says, no, Dr. Kirtley, you're not getting reimbursed for this. And so I was very thankful for SCMC to help me with that transition. And I've learned so much, even from my practice managers and others, that, hey, you get better over time, right? And we figure out how to talk to them and how to properly get authorizations. But with that, yes, it can be done in the office, and I used to do them in the office. The OR setting is and you can't get away from the fact it's safer, right? You've got a team, you've got a staff there, and you've got sterile conditions. And so, but if there was someone, if they had out-of-pocket cost differences, you could do it for less cost in the office, absolutely. And I do the same thing. I do trigger finger in my office without cutting the hand. Again, I don't want to bore you, right? We'll run on, but there are multiple procedures inside the hand that can be done without cutting. And that's really the cool things. I try to offer the same thing for each joint, right? The knee and the ankle and the foot. And by having an alternative, whether it be a high concentration anesthetic, a micro-invasive device, or a heat treatment to a nerve, right? That maybe gives somebody an alternative option, right? I'm not saying it takes the place of a surgery. In most cases, the surgeries need to be done, but if they've already had that surgery, or if we could just treat the pain without it, right?
It's very interesting.
Someone had asked a question about, what was it, bursitis?
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 Of course.
Okay.
I don't remember.
Somebody did submit a question and was asking about that, so I don't know.
I'll speak to it. So right up
I know
our alley,
my
right?
mother-in-law actually had it, though. I just remember she was fascinated with that word, bursitis. And she listens to our show, so shout out Paula Bennett. You're the best mother-in-law. But go ahead.
Yeah, so a bursa refers to, if you think about any tendon that has to slide or move, our bodies are amazing, right? How many times we can move a joint. So, and one of we want to lower that friction, right? And how the body lowers the friction is have this tiny little layer of fluid in between those surfaces, and that's a bursa. So you have this little capsule or this layer that encompasses fluid. And so now if you, over time, let's take the shoulder, for instance, it's very, very common, subdeltoid bursitis, right? And then there's this subacromial space. And so without using fancy terms, the tendon that lifts your arm, it slides up under this bone, right? And so you can either be born with that bone angled slightly down. You can have irritation. You can be throwing too much, right? Repetitive motion. And believe it or not, tendons, like nerves, as they become irritated, oftentimes they'll get thicker, not smaller. So if you have a limited space, exactly, they start to swell and get inflamed, right? And you get bursitis. But if that tendon is trying to slide through this limited space and now you're trying to fit a bigger tendon through a limited space, what's happening now? You've got a mechanical abrasion, right? Or a mechanical scrubbing type mechanism. And so now that bursa, if it doesn't, eventually it damages the tendon, cuts the tendon and it can tear, and you can get a rotator cuff tear. But most of those start with bursitis. Remember our tiny little fluid layer. And it's very obvious on ultrasound. And that's the cool thing, is that if you saw, say, an injection being done on ultrasound, it's a tiny little 1 millimeter space. The ultrasound allows you to not miss that space and go, oh, there's the bursa up there. And then you drive that needle right in. And so you feel the medicine inside the bursa, boom, it calms it down. And then with proper physical therapy, meaning, hey, sometimes if they've got a downsloping acromion, I don't want them doing Y's and T's, right? I want them doing external, internal rotation exercises, right? And then so you can look on ultrasound, do they have a thickened tendon or is it just a downsloping? Is there cortical irregularities? Is there something else wrong with the tendon, right? And so I can put medicine in whichever space is needed and then teach them about activities. Hey, you really don't want to have to buy that cuff repair at your age. Let's try to avoid doing 100 dishes at that top and get your husband to do that, right?
Yeah.
Or, so
lifestyle changes.
absolutely, lifestyle changes, ergonomics, and you can make that recommendation by seeing the anatomy in the visit, right?
She always would joke because she said it was a sports injury. So she said she was very athletic.
Yeah.
But
That's
I
right.
don't know that issue was. But
you can
anyways.
This has just been so interesting.
I know,
I
it's
feel like we could
fascinating.
go on and on and on, but
Yeah,
unfortunately
we do have to
can't.
wrap it up,
I
unfortunately.
understand.
But
But we can have you back on later. We can have you back on again.
of course, we will have to. So if someone wants to come see you, do they need a referral from their primary care? Can they just make an appointment with you?
Some insurances can come straight in, and then other insurance like TRICARE and VA and certain ones do need a referral, and so they can call our main line, and then our staff can walk you right through it.
Okay.
Cool.
Yeah, and we'll just probably put that in the description where people can contact your office,
That'd be great.
so people can find that. But I do have one last question, which
sure.
is not a serious question at all. But we always like to ask, since our docs spend so much time here, what's your favorite meal in our cafeteria?
We
or
see you in the
site?
cafeteria regularly. So
I am spoiled by our cafeteria. Those ladies are amazing.
They are.
And they take good care of our people, right? And they're amazing. They do a fantastic job with their curry dishes and their salmon. There's
love the
2 or 3 different salmon dishes that they knock it out of the park. And I honestly, sometimes I go back to my office all the way over at the ASC, and I'm sitting there, and I'm like, I've got to walk back over and tell them how good this is. Right? Yeah, because they do a great job.
Well,
They
I
really
think
do.
they'll appreciate that because they get a lot of compliments when we ask that question.
yes,
So.
yes, they do a great job. So
Well, thank you so much for having me. I appreciate it.
Yes,
thank you for coming on. I knew it was going to be interesting because I have held you hostage in the cafeteria a few times to ask for some free medical advice, but we do encourage office visits. Or you can listen to the podcast and learn more. So thank you for joining us, and thank everybody for listening.
Thank you.
Thank you.